Take my mask off. All right. All right, good morning, everyone. Thank you so much for joining. For the next hour, what we're going to do is go over implementing bubble CPAP in the delivery room, how to set it up, how to do a transfer, all without losing PEEP. And I'm going to start with just the background of why we are implementing bubble CPAP. And as many of you know, we were doing simulations this past year, the small baby simulation. So bubble CPAP is really a component of us implementing neuroprotective strategies for these tiny babies. So I'm going to start with a presentation, Golden Hour and Beyond, which really gives us the backdrop for not only implementing the bubble CPAP, but implementing neuroprotective strategies for our most fragile babies. And as a caveat, we're going to start with implementing bubble CPAP on those babies that meet criteria and who are less than 30 weeks. All right, so Golden Hour and Beyond. So when we think about golden hour, it's really not limited to the first hour, but really encompasses the first hours and days after birth. That there isn't really a universal description of the model, but there are several guidelines and standards that really what we're trying to do is reduce morbidity, mortality by delivering high quality, timely, and efficient care, basically standardizing our approach. So the elements of golden hour, many of these are probably very familiar to you because we participated in the CPQCC initiative several years ago now, implementing golden hour. And so it encompasses the initial delivery room management, thermoregulation, ventilation and oxygenation, glycemic control, infection prevention, and of course, creating a neuroprotective environment. So in the delivery room, look at all the ALS nurses we have on this call, and you are so familiar with this, right? It's all about teamwork, leadership, communication, having a skilled team, for which we are extremely fortunate to have all of you, utilizing checklists and simulation. And that was what we were doing this past year with the physicians primarily and Megan and some of our nurses. And we had limited the simulation to that group because of COVID. We needed to just have a finite number of people that could be in a room at any one time. So as you can see here, I think communication is also one of the most important elements. And in this joke here, it says, and that is why we lift on 3. And so how many times when we have looked at,
Hello.
Good morning.
Hi.
Looked at bad outcomes or untoward outcomes, and we can see then that often the root cause of that is somehow related to lack of appropriate communication. So why do we have a standardized approach? And implementing a standardized approach to golden hour can improve outcomes. And that was what we found when we implemented the CPQCC initiative with golden hour. And that was, we can decrease hypothermia, we can decrease hypoglycemia, and we can decrease time to infant stabilization at admission. And that's led to you guys always checking that temperature prior to us transferring the baby. So I'm hoping that that person who's ringing the doorbell is getting in. So I am going to just also bring it up on my, sorry for a second. Okay, they've got it. All right. So these are important elements of having that standardized approach for the initial delivery room management. But why is the preterm infant at such great risk? And we know that some of the challenges are transitional physiology. They have immature adaptive systems. And of course, we know that they have very fragile brain structures. So when we're thinking about our little ones, whether or not they're a term baby or a preterm baby, all of them have lungs that are fluid filled in utero. But in addition, our premature babies have immature lungs, fluid filled. And then they have to transfer into a gas exchange environment. Puppies and babies, I love it. So quite frequently, these little ones require CPAP in addition to oxygen support. Secondly, they have immature myocardium, which influence their cardiac output. And so the immature myocardium in preterm infants increases their risk of dysfunction. They have limited ability to increase contractility. And the systemic vascular resistance, which increases after delivery, increases their afterload, puts a strain on their immature myocardium. And this leads to decreased cardiac output and also leads to hypoxemia, hypotension, all of which gets exacerbated by asphyxia, sepsis, and acidosis. So that's why these babies are particularly at risk. In addition, they also have functionally immature hormonal and organ systems, which also predisposes them to hypoglycemia, cold stress, and of course, interventricular hemorrhage. They may also have delayed, what we also do in our initial resuscitation, we have 3 ALSs that have joined us in the room, so hence I'm looking a little distracted. They're trying to watch it on a little iPhone over there, and I'm offering them my laptop. So what is the initial resuscitation? You're all familiar with delayed cord clamping, appropriate use of supplemental oxygen, use of non-invasive ventilation, thermoregulation, and of course, neuroprotection, all of which are vital components to the immediate postnatal care. And when you think about each of these strategies and interventions, they're really complex. And so one has an impact upon the other. And in the first few minutes after birth, if we don't use things appropriately, these can cause structural changes, trigger inflammatory or pro-oxidant cascades, and have lifelong consequences for these preterm babies. So delayed cord clamping. The neonate remains attached to the placenta for 30 to 60 seconds. The goal, obviously, is to recapture as much circulating blood from the placental vasculature. And what that will do is increase fetal hemoglobin, will increase oxygen content and oxygen delivery capacity. So tremendous benefit for our preemies. Ventilation and oxygenation. We've been all familiar with NRP, using targeted oxygen saturation, use of early CPAP, and prompt intubation if not responding to positive pressure or requires chest compressions. Interestingly enough, I want to go back to the delayed cord clamping. For the new edition, this 8th edition for NRP, they're changing the 4 questions. And one of the 4 questions now is going to be, what is the plan for cord clamping? Why are we targeting oxygen saturations? We want to obviously reduce the risk of hyperoxia and the sequelae, which can trigger inflammatory cascade and then have free radical production from oxygen toxicity. That leads to injury to our type 2 alveolar cells, which leads to impairment of surfactant production and therefore acute lung injury. So why CPAP? We know that preemies, they have weak respiratory muscles, they have high chest wall elasticity, they have decreased respiratory drive and decreased surfactant, all of which leads to decreased functional residual capacity, poor lung clearance and aeration, VQ mismatch, and greater airway resistance. So you think, why on earth would we do CPAP? Well, the benefits of CPAP, we know that PEEP promotes lung fluid clearance and expansion. It can increase our functional residual capacity, it improves VQ matching, decreases energy expenditure, and decreases the need for intubation. And now Spencer's going to show us the pig lung, which I'm hoping none of you had bacon for breakfast.
I couldn't get the link to pull up on the Zoom there. All right. What's this? New share. Here we go.
Okay, so bagging without PEEP.
Yeah. You guys can see that okay? Yep.
You see how the lung collapse, so we're not really recruiting hardly any alveoli. They're just going in and going out.
Okay.
How fast he's squeezing that back. All right, now we're going to add PEEP to this. Okay, PEEP supply. Now you can absolutely see the alveoli being recruited by the hundreds of thousands, which is why the lungs are staying.
So they stay inflated much longer. And you can't over ventilate this patient?
You can, you certainly can. So you adjust your PEEP anywhere from 5 to 20. 20 is the max I would do. And you just watch the patient. You're driving for an O2 sat of around 94. Doesn't even need to be, 100%. And you adjust your PEEP accordingly. The only way you can increase the FiO2 when they're already on 100% O2, the only way to increase that number is through PEEP. Not by breathing faster. That's going to cause more intravascular pressure, decreasing the cardiac output, decreasing the SpO2, causing you to bag faster, and you just get into this vicious cycle of bagging down.
What's your current PEEP setting?
So our current PEEP setting on this one right now is 20 millimeters of mercury. We can back it back down. Okay, this is 10. Go ahead. So this is 10 of PEEP. Still, you can see it's recruiting alveoli. This is 15. This is 5 of PEEP right here. So you can see that's our physiologic norm. That's almost like not having the PEEP going on at all. So that's 5. You can just cruise this up to 10. And now we'll get more functional reserve volume. We got more tidal volume now going on. We're recruiting tens of thousands of alveoli. There's 15. We're starting to just get into that bagging noise, and then there's 20. You can see the difference when flight crews bring people, when we put people on our ventilator on PEEP, and then if you go to ventilate the patient with the BVM, you don't have a PEEP valve on, watch what happens to your lungs. So let's say the crew doesn't know what they're doing, or the ventilator's alarming, or worse, you get them in the hospital, RTs, they're bagging them. Watch what happens to my lungs when I take away that PEEP and you just go straight BVMing. That's what happens. We lose all our pressure.
Oh, and then some, yeah,
So-
like you were like in the negative.
Yes, so it clinically doesn't make sense for anybody on a ventilator to put 6 to 10 to 20 a PEEP. Oh, I don't know what's going on, the ventilator's alarming, pulling them off and BVing them without the PEEP valve on. They clinically cannot get that. People squeeze faster, but that's horrible.
So you got a patient and you're BVMing them and their sats are 80, their sats are 80, their sats are 80. You throw that PEEP valve on, you keep that O2 in their lungs longer.
Look,
And you
none of that,
recruit those
you're recruiting alveoli.
Yeah.
What's the hardest part about blowing up a balloon?
The fact that it's pushing back against you.
The initial, once you get that balloon going,
It's
it's
easy.
easier to blow up. So that's what your PEEP is really doing. Distinguish
There's already a
alveoli.
pressure there, and
Yeah.
then when you try to inflate it,
PEEP,
it's that much easier.
use it.
Use it.
I made a mistake of not using it.
Cancel. That. Now get back. Share Screen. Share.
Perfect. So you get the idea of the importance of PEEP and maintaining CPAP, which is why we are implementing this program, and also we'll show you how we are going to transfer these babies without losing that PEEP. So thermoregulation is another element, obviously, of the golden hour and an important component. And you guys already have your pre-set up in the delivery room with your chemical mattress, the turkey bag, which we're not calling a turkey bag, in front of the parents, radiant warmer, hat, all of these strategies to maintain adequate thermoregulation. And obviously, admission temperature is a very strong predictor of mortality. And that's another reason I know that you guys are very diligent when you bring that baby up, and you're very proud when that first initial temperature is 98.6. And then we put them on the radiant warmer, and we do our line placement, and then we sometimes watch that temperature plummet. But anyway, that's something that we're working on. So thermoregulation, we know it's unique to the preterm infant because they have disproportionate body mass to surface ratio. They have a lack of brown fat. They don't have any epidermis, 2 to 3 layers maybe. That leads to excess water loss, fluid and electrolyte imbalance, but also excessive heat loss leading to hypothermia. So for us, what we're going to remind our staff is it's important to close that baby Leo and initiate humidity as soon as possible. We're also implementing some strategies that can help maintain thermoregulation during line placement. Infection prevention obviously is a huge component for these babies, doing a sterile line setup. And I know hopefully you don't have to do emergency line placement in the delivery room. Use of soap rather than chlorhexidine with alcohol. Securing the lines with a purse string method. Use of hand hygiene, gloves for all contact, and also for us maintaining skin integrity and really monitoring for areas of potential actual breakdown. And of course, timely administration for antibiotics. So the brain, one of those major organs that we want to protect. The periventricular germinal matrix is obviously highly vascular. It's susceptible to fluctuations in blood pressure and intravascular volume. Postnatal stress and wide swings in blood pressure increase the risk of IVH, and the oligodendrocyte precursors are susceptible to oxidative injury. And we're going to talk a little bit more about that. So what is the timing of and the onsets of IVH? About 50% occur in the first 24 hours, 80% by 48 hours, and about 90% by 72 hours. So that's why our golden hour and beyond, we're really focusing on the first 72 hours of life. And of course, by 7 days of life, about 99% would have occurred. Some of the risk factors for these little ones: mechanical ventilation or asynchronous ventilation, pneumos, hypocarbia leading to vasodilation, hypocarbia leading to vasoconstriction, acidosis, and hypoxemia, which is why we want to manage their respiratory and their ventilation strategies very, very carefully. And if at all possible, avoid intubating these babies. Cardiovascular, impaired autoregulation, immature brain passive, pressures, hypovolemia, and hypotension. What it means is these babies have limited ability to control their cerebral perfusion and cerebral blood flow during high or low systemic pressure. So the cerebral blood flow is determined by moment-to-moment changes in the blood pressure. So when we're monitoring that blood pressure in these micro preemies, and who actually knows what a true blood pressure, adequate blood pressure is for these babies, when we're watching that change, we're also thinking about what's going on in that brain. So that's changing that cerebral blood flow moment to moment. So other risk factors for these little ones: hypoglycemia, sepsis, coagulopathies, anemia, and of course, stress. We're going to talk about stress. So what's neuroprotection? I think it was initially applied to those babies with HIE, but it was really used to characterize substances or strategies capable of preventing cell death, which is what we want to do. But now it encompasses all kinds of interventions that promote normal development, prevent disabilities, and they're becoming more and more standard in the care in our NICUs and PICUs. Next year's CPQCC project is actually the NeoBrain, where we're going to be focusing on strategies to provide neuroprotective strategies in the NICU. There are 5 domains, and what we're going to be focusing on is prevention. But apart from prevention, we have containment of injury, increasing cellular tolerance, salvaging any injured cells, and then hopefully growing and nurturing new cells. So what are some potentially better practices? Antenatal steroids, huge for our babies. Optimizing delivery and post-delivery care, which is in your domain in the delivery room. Optimizing respiratory support. Treating hypotension, minimizing pain and stress, optimal positioning, which is why we initiate midline positioning for 72 hours, and of course, engaging parents. They're a huge component of reducing stress in these newborns. So appropriate respiratory support involves non-invasive SpO2 and CO2 monitoring, avoiding rapid IV flushes, so carefully withdrawing fluids, our blood samples, and reinfusing blood and our other samples and fluids into the UAC or UVC. Midline positioning, maintaining the head of bed flat or slightly elevated. Careful diaper changes. As you can see here, how often do you see us lifting those legs up, but then potentially putting that additional pressure on that baby's head? And suctioning only when required. So midline positioning, what does the evidence actually support? Midline and neutral head positioning and head of bed at 30-degree elevation for the first 72 hours of life in babies less than 32 weeks was used to prevent alterations in cerebral blood flow. And what they found, there was a significant decrease in tissue hemoglobin index and tissue oxygenation index during head rotation in those little ones less than 26 weeks. There was a significant increase in cerebral blood volume during 90-degree head rotation in babies less than 1,200 grams. Jugular blood flow was decreased with 90-degree head rotation, and a significant increase in cerebral blood volume with the head tilted down. What they also found, more importantly, I think, was no adverse consequences were identified with midline positioning. So it seems like it's a really good thing to do. So is this midline positioning? No. Is it comfortable? No. So imagine these babies that have their head in this position, or even us, for a period of time, and how painful that is. Is this midline positioning? Look how happy this little baby is. So we've got, they are on their side. So midline position doesn't necessarily mean that you have to have them supine. What it means is you've got their nose, their knees, their umbilicus all in alignment. So this is midline positioning. So what about pain and stress? When you're thinking about these micropreemies and they've been swimming around in their fluid-filled environment that's dark and warm and sound and light and muted, and then we bring them out into a noisy, bright environment in the labor and delivery room, and then in the NICU, they're exposed to noise, light, touch, sound, very, very stressful. And sometimes what I'm telling parents is, if you think about going Christmas shopping, when you could go Christmas shopping in the mall on Christmas Eve, and how incredible stressful that is, because it's impacting every one of your senses. That's basically what's happening to these preterm babies. If we continue with pain and stress for these babies, it impacts their long-term physical and psychological development. It is actually neurotoxic, and it can reduce their brain size. So we need to think about how we approach these babies when we're coming to their bedside. Also protecting sleep. REM sleep deprivation results in disordered sensory development, learning and memory, and a smaller brain size. Any one of you who haven't had enough sleep, you know you're kind of in a little bit of a fog. So again, being mindful when we're going and examining these babies to find out, is this a good time or is this part of their sleep cycle? So neuroprotection overall, what we want to do is prevent injury. We want to minimize stress. We want to provide appropriate timely interventions. And really what our goal is to enhance human potential and human connections. So when these babies are ready to go home, they're optimized in their outcomes and they are truly bonded with their parents. Our goals right now are to implement bubble CPAP in the delivery room in November. We want to transfer and weigh the babies without removing CPAP. We want to provide neuroprotective strategies, all of those that I have just given an overview of. And over the next several months, we're going to introduce and implement checklists so that we can then standardize all the tasks that we do upon admission. So questions? Feedback. Next, we're going to go into some awesome videos.
Right.